Welcome, everyone. I'm Ron Brookmeyer, Dean of the UCLA Fielding School of Public Health. Thanks very much for joining us tonight for the second webinar in our new series called Fielding Focus. COVID-19 continues to wreak havoc and make very plain that the uphill battles that we face in our fight to achieve health and wellness for all are in many ways becoming even more steep. But part of what keeps me going, why I refuse to lose hope, is that I have the tremendous good fortune to work with colleagues like those you will hear from tonight. Linda Delp, Chandra Ford, Randall Kuhn, and Jessica Gipson are relentless in their pursuit of collaborating to find and implement solutions, and they are equally as dedicated to training and mentoring the next generation of public health leaders. I'm so grateful to Jessica for bringing our panel together and for serving as moderator this evening. Jessica is one of our terrific faculty members in our school's Department of Community Health Sciences. Before I pass it off to Jessica, a quick mention that next Tuesday, May 12th, Professor Michael Prelep will moderate a panel taking a closer look at COVID-19 wellness and healthy living. For now, it's my pleasure to pass it off to Jessica so that we can turn to addressing COVID-19 and vulnerable populations. Jessica.
Thank you so much, Ron, for that wonderful introduction. Hello, everyone. Welcome. I'm delighted and honored to be here with all of you. Tonight's panel provides an opportunity to discuss with our expert panelists how the COVID-19 pandemic intersects with existing social, health, and economic inequities to differentially impact populations. Just a few housekeeping notes before we begin. Tonight's webinar is being recorded, so this session will be available later this week on the Fielding School's website, ph.ucla.edu. Also, we really encourage your questions throughout the presentations today from all of you, and you can submit them at any time during tonight's webinar. Just click on the Q&A button near the bottom of your screen. And if you would like to tweet during the event, please use the hashtags #UCLAFSPH and #UCLAFieldingFocus. The way we've organized tonight's webinar is that I will briefly introduce our three panelists, each of whom will present for 5 minutes, and then we'll open it up to questions from all of you. So to start us off this evening, I'm delighted to introduce my colleague, Dr. Chandra Ford. Chandra is the founding director of the Fielding School's Center for the Study of Racism, Social Justice, and Health, and is an associate professor of community health sciences at our school. Chandra's expertise includes, among other topics, examining how racism and social inequalities lead to adverse health outcomes and healthcare disparities. Her innovative research provides tools that can be used to understand and measure racism, as well as to guide anti-racism efforts. Chandra and colleagues at the Center for the Study of Racism, Social Justice, and Health have been doing some extraordinary work around COVID-19, so I'm really very pleased that she could join us today. Chandra?
Hello there. Thank you, Dr. Gipson. When did racism become relevant to the COVID-19 pandemic? The answer, neither President Trump's initial framing of it as a Chinese disease, nor the subsequent xenophobic violence directed at people presumed to be Chinese, entangled an otherwise non-racial pandemic with racism. Rather, racism often lies just beneath the surface in stigmatizing diseases. The targeting of Chinese persons as perpetual foreigners and the suggestion they pose a threat to the physical and economic health of the nation are predictable manifestations of specific ways racism has operated and continues to operate in the United States. There's growing interest in addressing racism as a public health issue. So tonight I define racism, offer 2 implications for the COVID-19 pandemic based on the HIV epidemic, and offer 2 recommendations for moving forward. First, however, as with many of you, I work in Southern California on lands originally inhabited by and cared for by the Gabrielina Tongva peoples. While it is a privilege to serve on the UCLA faculty, no doubt the displacement of these nations continues to enable the enrichment of our land-grant institution. This acknowledgement is a reminder of the need to make visible the historic and ongoing injustices visited upon the indigenous peoples of the Americas, which has many implications, including for the COVID-19 pandemic in Indian country, as the work of Randall Kuhn and others suggests. Racism is often defined narrowly as overt interpersonal or institutional discrimination, but this obscures the dominant structural ways by which it contributes to health inequities. Former president of the American Public Health Association, Kamara Jones, defines it as, quote, a system of structuring opportunity and assigning value based on the social interpretation of how one looks, or what we call race. That system unfairly disadvantages some populations while unfairly advantaging other populations, and in so doing saps the strength of the whole society through the waste of human resources. There are many implications for the COVID-19 pandemic. Emerging data reveals stark inequities in death by race and ethnicity and other sociodemographic characteristics that are tied to inequities in underlying chronic conditions. However, those chronic conditions are known to be driven by structural racism and the social determinants of health. Lessons learned from the HIV epidemic include that having access to healthcare, though critical, does not eliminate disparities, in part because disparities also occur within the healthcare system and the timeliness, aggressiveness, and quality of services patients receive across the continuum of care. That is, from diagnosis to getting linked to care, remaining in care, and adhering to prescribed treatment regimens and medications. With infectious conditions, delays or suboptimal care affect both the patient and those with whom the patient interacts. The HIV epidemic also shows that the development of effective treatment does not necessarily eliminate disparities. Although African Americans had higher rates of AIDS than their proportion of the US population would suggest, since the beginning of the AIDS epidemic, it was the introduction of life-saving antiretroviral therapies in 1996 that exacerbated Black-white disparities in AIDS. For the first time, Blacks then overtook whites in accounting for a greater share of all US AIDS diagnoses. Importantly, that pattern persists. The stark racial and ethnic disparities laid bare by the COVID-19 pandemic serve as both a warning and an opportunity. They warn that colorblind approaches that do not address racism directly have historically failed to eradicate inequities. Needed are anti-racism strategies targeting structural racism. So I offer 2 recommendations. First, Kamara Jones defines health equity as assurance of the conditions necessary for everyone to attain health. I recommend that research and interventions not focus primarily on race and ethnicity, or even on the underlying chronic conditions, but on the root causes of disparities in those underlying conditions. Secondly, I caution against relying primarily on the military or the police as the first responders to this public health problem in these vulnerable populations, because legitimate reasons exist for people to distrust them. Imagine employing instead community health workers, social service professionals, and librarians. In conclusion, movement toward equity has always required champions fighting from inside the field. Unless our responses to the COVID-19 pandemic challenge its racial framing and prioritize the needs of racial and ethnic minorities, immigrants, and other vulnerable groups, COVID-19 is likely to persist in pockets of our society. As long as it does, it will be a telltale sign that racism and other forms of oppression persist in our society too. Thank you.
Thank you so much, Chandra. Your words, saps the strength of the whole society resulting from structural racism, really resonated with me. And I really appreciate your discussion of structural racism as a core or root cause of these disparities, both in COVID and beyond. So it's now my pleasure to introduce Dr. Linda Delp. Linda is the director of the UCLA Labor Occupational Safety and Health Program, a nationally recognized center promoting safe jobs and worker health through teaching and education, research, and policy advocacy. Linda's work focuses on occupational health disparities, health and safety conditions facing workers in non-traditional and informal employment structures, and the effectiveness of worker education and empowerment programs to change workplace and public policy. She also serves as an adjunct associate professor in the Department of Community Health Sciences in the Fielding School. And as an interesting side note, Linda happens to be a double alumnus of our school, having earned both her MPH and PhD degrees here. Given her deep experience in worker health issues, I'm so glad that she's here with us tonight to share her insights. Linda?
Thank you, Jessica. At LOSH, the Labor Occupational Safety and Health Program, we promote worker health and safe jobs through outreach, education, and research designed to inform policy. Next slide, please. My comments today are set against a backdrop of years of experience with workers in a variety of industries, as seen in this slide. The slide also shows a COVID-19 infographic we recently completed, which will be distributed statewide to farm workers in English, Spanish, and Indigenous languages. Based on these experiences, I want to highlight 3 key points. First, the inequities we see today with certain groups of workers disproportionately facing a high risk of exposure to the virus and without adequate protection are not new, but have become more visible. Next slide. This slide depicts an analysis by the Center for Economic and Policy Research of frontline worker demographics in 6 industries. By the way, this data is also made available by the center by state and by occupation, which is a more useful way for looking at inequities. These workers are disproportionately women, and in some high-risk occupations, people of color and immigrant workers are overrepresented. Compounding the risk from unsafe jobs are low income and lack of health care. But the data we need to analyze their differential exposure in this crisis is sorely lacking. Public health workers themselves on the front lines have limited capacity to document the occupation of those who test positive, and requirements for employers to report COVID-19 illness in their workforces are open to interpretation. So we rely on media, researchers, and worker advocates who crowdsource data to learn about clusters and about heartbreaking stories, as the one that really touched me in the New York Times today about the deaths of non-direct care hospital workers who often aren't visible and don't make the headlines. Next slide. So how can we address health inequities with public health interventions in the workplace? I want to illustrate this with the cliff analogy framework developed by Dr. Kamara Jones, past president of the APHA. Inequity in this slide is depicted by 2 groups. One group is set safely back on the cliff of good health, the other near the edge and at risk of injury or death from falling off. The first group has additional interventions as well to protect them, which are lacking for the second group. The fence in the diagram depicts primary prevention, or basic protections in the job, like those we may have seen emerge recently, but a little late, at our local grocery stores to ensure safe distances between people. And like employers who comply with Kellish's aerosol transmissible disease prevention standard, a model to protect workers in the healthcare industry. The safety net indicates secondary prevention measures such as access to testing, paid leave to quarantine, and social support services. And here, tertiary prevention, depicted by the ambulance, includes access to healthcare, workers' comp benefits, and other physical and mental health services. So as businesses reopen, we must ask the key question: Are these different levels of protection in place for all workers? Or will some still be disproportionately affected with a lack of protection, as in the group of green workers depicted in the slide? The second point I want to make is that vulnerability to illness is not a trait inherent to certain groups of workers. Rather, vulnerability is shaped by social determinants, as those shown in red in this slide. So, for example, we may see inequitable health outcomes in illness data because certain groups are overrepresented in precarious jobs. Or barriers to OSHA protection may mean that employers who do not protect workers are not cited by worker safety enforcement agencies because standards are non-existent or staffing levels are inadequate, or because groups of workers like day laborers and domestic workers are not afforded the protection of OSHA regulations. So these vulnerabilities are a result of cracks in worker protection policies through workers can fall. My third point is that social determinants of health and inequity are a result of unequal power relations in society. In other words, who makes decisions and based on whose interests. So if we want to create a vision that puts public health and worker health front and center, workers must have a voice without fear of reprisal. Instead, what we sometimes see are strong-arm tactics to force workers back to work despite protests from the workers themselves about unsafe conditions. Next slide, please. I want to very briefly examine meat and poultry processing workers who've been in the news recently in terms of the three key points that I made. In terms of inequities, this industry is comprised of a large number of immigrants and refugees. In one plant, workers spoke 40 different languages. The social determinants of illness and injury are also rampant in this industry. 20 plants have been shut down due to COVID-19 clusters related to crowded and unsafe working conditions. And unequal power relations play out in terms of workers' fear of reprisal from their employers if they take time off due to sickness or speak up about working conditions. But these dynamics also ensnare public health departments who have in some cases shut down plants, but now have been trumped by last week's executive order invoking the Defense Production Act to maintain operations at these plants. This to ensure that Americans have access to a sufficient supply of meat protein in our diets. And in our own state, the employer at a meatpacking plant near Fresno, where 100 workers have tested positive, has not allowed entry to the local public health department. This mandate to maintain operations in these plants contrasts with the unenforceable guidance issued by the CDC and OSHA to safeguard those workers. So the United Food and Commercial Workers Union and a nationwide network of worker advocates, national COSH groups, have stepped up outreach and support for workers. They, along with other worker advocates, are pushing policy reform, including an OSHA infectious disease prevention standard that will be enforceable. Next slide. So finally, I want to consider some questions currently under debate and think about future directions. The key questions right now are what worker safeguards must be in place as businesses reopen, and how will they be enforced? So I just came from an LA County Department of Public Health focus group about this very question, and I'm really pleased to say that they're making an attempt to ensure that both employers and worker advocates are represented in the discussion. The other question is, how can we ensure that workers who become ill receive benefits when needed and are not caught in an endless debate about whether their illness is work-related or not? In terms of future directions, personally, I don't want to go back to the so-called normal that existed before. We need to use the opportunities that present in this time of crisis, first, to collaborate to secure accurate data so we can monitor the distribution of illness among different groups of workers who are disproportionately exposed to risks. Then we need to radically change the fragmented structures and systems currently in place that allow workers to fall through the cracks. Next slide. I want to end by acknowledging the many tragic deaths, the people behind the statistics, as well as the public health heroes and the state and national network of worker advocates who are doing their very best to ensure that workers do have a voice in decisions that affect them, and that workers are seen as essential and not expendable. Thank you.
Thank you so much, Linda. I really appreciated your timely insights on workplace harms and how we can work at these primary, secondary, and tertiary levels to address some of these cracks in worker protection policies that you mentioned. So now we'll move on to our final panelist, Randall Kuhn. He is a demographer and sociologist. He serves as an associate professor in the Department of Community Health Sciences at the Fielding School and as a faculty affiliate of the UCLA California Center for Population Research. Randall employs a wide array of research methods and data to study the social determinants of health. His research focuses on the demography of vulnerable populations, including aging and homeless populations, as well as global and immigrant health. Randall has been doing some really important work to address homelessness here in Los Angeles during COVID-19 and ongoing. So I'm so glad to have him here with us to share his perspective. Randall?
Thank you so much, Jessica. Chandra and Linda did such a great job of framing out a lot of the structures and pathways that drive the relationship between COVID-19 and vulnerability, that I'm really going to start. I'm just going to focus on the facts and what we're trying to do with respect to homelessness. And, you know, this conversation starts with what we know is the most important thing we can do to protect ourselves and our neighbors from COVID-19, and that is to stay safer at home. And of course, the question that immediately comes to mind for me is, what do you do? How can you stay safer at home if you don't have a home? And that pretty much summarizes the problem in a nutshell, but we can go quite a bit deeper in terms of not just exposure to disease, but also vulnerability to disease among the homeless population. LA County has 58,000 homeless people. Many people are probably familiar with that statistic. 75% of them are unsheltered, meaning they're living in tents, cars, or sidewalks. And roughly 1/3 of them are African American, even though Black people make up just 10% of LA County's population. So one big driver of vulnerability in the African American population at sort of the level at which it manifests is homelessness and underhousing. In terms of health, when I first started thinking about what COVID-19 was going to be like, you know, one immediate thought, and I've heard a number of people express this, is that for a homeless person, every day is like a COVID-19 pandemic in terms of the risks that people are facing, of all manner of infectious disease risks, non-communicable disease risks, and so on. I'm part of a group that recently released a report on homelessness and public health in LA, and we didn't really report any new findings. We simply aggregated some of what we already know about homelessness and health. And that is specifically that compared to housed people, unhoused people have roughly a 10 times higher risk of HIV, a 15 times higher risk of hepatitis C. The excess risk of tuberculosis is almost incalculable, but maybe it's 100 to 1,000 times higher. In 2018, more than 1,000 homeless people died in LA while homeless, mostly on the streets, meaning that's not counting the people who died in hospitals or finding their way to family or to a home before they died. That makes them about twice as likely to die as a typical person. And finally, studies of chronic disease risk and homelessness. And again, we don't have very much data. One of the big things that I'm trying to work on is better ways of developing representative data that help us to understand what are the, not just the health conditions affecting homeless people, but what are the needs, what do they want, what is the path to recovery look like? And but to the extent that we have existing surveys of chronic disease and aging and homelessness, right, what we know is that homeless people tend to present in surveys or at emergency rooms or in surgical complications with health risks that are more typical of someone 15 years older in their chronological age, right? So homelessness, the long-term exposure to homelessness, and we suspect, although there's not much data on it, that unsheltered homelessness would be even more so. The long-term exposure to homelessness is a process of accelerated aging, right? It breaks down your body from the outside in and the inside out. And it's that final point about accelerated aging that led a group of us, led by Dennis Culhane at the University of Pennsylvania, to write a report immediately after the onset of the pandemic for the National Alliance to End Homelessness that identified the truly existential threat that COVID-19 posed to homeless people. And that is, aside from whatever the risks are of transmission, and we can get into those, right? There are a lot of excess risks that may affect homeless people. The most basic thing we knew is that if old people were more vulnerable to COVID-19 and homeless people had the health risks of someone 15 years older than themselves, then we estimated that the risk of hospitalization and fatality from COVID-19 would be as much as 3 times higher for homeless people than the rest of the population, right? And so that is, we have every reason to think, right, that not having a home would make it really, really difficult to be safer at home and to shelter in place. We know that homeless people are dependent on congregate service spaces, whether it's crowded shelters or soup kitchens or what have you, and that homeless encampments mostly don't have access to sanitation. And so there are many reasons why we would think that homeless people would be at higher risk of exposure to COVID-19. But what we know even more so is that if they got COVID-19, they would have potentially a 3 to 4 times higher risk of dying. And that was based on, right, we still need better numbers on what those exact risks would be, but in a way it's kind of beside the point. So on March 24th, as Congress was debating the CARES Act, we released this report and recommended that funding be made available to move, sort of our initial proposed plan was to move all unsheltered and half of all sheltered homeless people, including all of those who are over 65 or have any other chronic disease risks that would make them vulnerable to COVID-19. They should be, an opportunity should be created for them to move to either low density shelters or hotels. And increasingly over time, it's become clear that the more serious option was hotels. Use of hotels to protect homeless people emerged quickly as what could have been really a once-in-a-generation opportunity, right? To save lives by move people into hotel rooms so they can be protected, and at the same time, save the jobs of hardworking people. And again, do so, meaning hotel workers, do so carefully and not put them at risk, and to save an industry that's vital to our economy here in LA. LA County quickly moved to set up what they called Project Room Key, which is a state and local program that in LA aimed to house 15,000 of our most vulnerable homeless people, including all of those over age 65 in hotels. LAHSA, the LA Homeless Services Authority, and other agencies moved quickly to set standards for hotels, to open up those hotels, to equip them to basically function as homeless shelters, to start screening people into Project Room Key, and to develop an application for outbreak detection and screening that was just launched. We worked with LAHSA to set up an SMS mobile alert system that could also serve as a backup lifeline for clients in case the situation deteriorated even more. On April 5th, as the first hotel rooms were occupied by homeless clients, there was an incredible sense of hope among those of us working in this area that the COVID-19 pandemic, while posing a mortal threat, could also be a real opportunity, basically to do all the things that we said we should have done, but had never done. Come up with more resilient systems to shelter people quickly and find pathways into permanent housing for them, to reach out to homeless clients, to engage in a widespread response that would show empathy. And a month later, I can't quite say where we're at. The goal was to put 15,000 people into hotels. We're at about 1,700 rooms, but things have started to flatten out. And that's not because of LAHSA's capacity to put people in shelters. That's because largely because hotels still aren't signing up. They're still not getting on board. Partly the hotel companies haven't gotten on board to agree to allow homeless people into their hotels, and partly when hotels have agreed to sign on, sometimes neighborhoods and towns have protested against this. And again, on humanitarian grounds and social justice grounds, I find that quite objectionable, but also as a matter of public health, right? That the risks that homeless people face are not just risks to themselves, obviously, but any of us who cannot shelter in place, any of us who do not shelter in place, are potentially at risk of transmitting disease. And it's been interesting to me working in some cases with members of the homeless activist community, that we in the public health space, especially those of us at universities, try to be very careful not to label, not to say such and such person is poses a risk to others. But the point is, at this stage, we all pose a risk to everyone else. And people in the homeless community that I've spoken to are often of the mind to say, look, at this point, we need to mobilize people. People's empathy, their willingness to open up hotels, open up their hotel rooms, welcome people into their neighborhoods to stay in hotels in order to protect them, to save their lives, doesn't seem to be sufficient. And so appealing to people's interest in protecting themselves may be necessary. So that's where we stand. There's a plan emerging to provide permanent housing to people who are placed in the hotels. There's a desire and many efforts in place to expand the use of hotels, and there remains a real possibility to transform the way we approach homelessness in LA. But there are also a lot of risks that make me quite concerned. Thank you so much for your time.
Great, thank you, Randall. Again, another timely and extremely relevant presentation. Thank you so much. And for those of you watching, and if you haven't seen the front page of the LA Times today, there's a fascinating article on Project Room Key that Dr. Kuhn was talking about for further reading. So there are a lot of wonderful questions coming in from the audience. And so I wanted to go ahead and just jump right in. So the first one was directed towards Dr. Ford, but it seems that actually all of our panelists could potentially weigh in on this, but Dr. Ford, if you wouldn't mind starting. So this is from Lori Carter-Edwards, who says, thanks so much, Chandra, for your presentation and recommendations. Your point of reaching within the community is imperative. What is UCLA Southern California doing to hire contact tracers that reflect their communities? Some locations in the country are quickly hiring without taking this important factor into account. What are your recommendations?
Thank you for that important question, Dr. Edwards. I can't speak to exactly what the county is doing in terms of hiring people, but I will underscore that point that you're making, that it's not just enough to hire folks, that part of the concern that I and others have in terms of reaching out, in particular to racial and ethnic minority communities who have histories of mistrust with the public sector, the public health sector, police, and so forth, is that the folks involved need to be folks from their communities. And if they're not directly from their communities, then they should be folks who could be from their communities on some level. And so that is something that, as you suggest, I think is highly recommended in terms of a strategic long-term vision of how we might be able to do this kind of outreach work in communities over the long haul of the epidemic.
Jessica, could I add another element to that? I was talking the other day with the person at the California Health Department, Occupational Health branch, who oversees medical surveillance for workers. And we were talking about the really critical role that contact tracers play in the community. So I think one of the issues has been raised by this question, which is really critical. But given the health department and how they've been overwhelmed, I think, to the degree that we can hire more contact tracers and do our best to gather a bit more information. If the contact tracers can be trained a little bit to, from my perspective, think about the workplace. So for example, if I'm calling someone who's tested positive, there is an option in LA County to ask people their occupation, and the choices, I believe, are for them to mark if they're a healthcare worker or a firefighter, and I forget what the third one is, or other. But to the degree that we can get a little bit more nuanced about the kinds of jobs that people have who are positive, could be a really important database, number one, for seeing where workers are who are affected by COVID-19, whether that might have any relationship with their work. And then secondly, to not just think about contacts in the home and the community, but coworker contacts, which is a sticky situation, but absolutely critical to prevent the spread of illness among coworkers as well. So I just want to highlight how critical I think the role of those individuals are in the community and can be as well for workers.
Great. Thank you, Chandra and Linda. So Linda, we'll go ahead and continue with you. There's a question directed to you from Calvin Wong. Hi, Linda. What are the repercussions of companies who do not follow OSHA regulations? And what is OSHA's response to the employee protest and concerns?
So I'll answer that at two levels. OSHA's response at the federal level has been described by the former head of OSHA as missing in action. OSHA has no federal infectious disease prevention standard, which worker advocates at this point are pushing for to help to require that infection control practices be implemented in the workplace. And they have not been very present in terms of looking at worker protections and how to make sure that they are implemented at different workplaces. Cal-OSHA, which is the California OSHA program, is a bit different. In California, we have two regulations that are and have been required among employers. The first is the Injury Illness Prevention Program, which practically every employer in the state needs to comply with and have a plan in place to identify hazards, to take measures to protect workers from exposure. It includes training, communication, et cetera, et cetera. Cal-OSHA has issued guidance for employers for specific industries and across all industries, and says that employers under their injury illness prevention program must follow the guidance for protecting workers in their specific industry. So that standard does require employers to address the problem. In the healthcare industry, Cal-OSHA also has what I would call a model type of requirement for healthcare employers to protect workers, the aerosol transmissible disease prevention standard. It's the only state in the country that has that. And it came about because of pressure from frontline healthcare workers in the past who were exposed to infectious diseases. That said, that does require employers to take really important precautions in healthcare settings to protect workers, but the enforcement is a bit lacking. Cal-OSHA is woefully understaffed right now, and the way they've been responding to complaints about violations of protection for workers in the workplace is to send employers a letter and then rely on the employer's recognizance itself to protect workers. So in large part, they have conducted only very, very limited inspections to actually see what working conditions are like and to make sure that employers are complying with regulations.
Great, thank you, Linda. So the next question is from Mackenzie Neef Lane. This is for Randall. I am currently working as a medical assistant at the Occupy Medical Wheeler Pavilion Shelter for the medically compromised, unhoused population in Eugene, Oregon. Part of the issue that we have seen here in Eugene, which has the highest per capita rate of unhoused individuals in the country, is the serious mental health needs of the population. Shelters and hotels are not equipped to deal with these individuals' needs. Even our shelter, which has access to some medical oversight, is really ill-equipped. Yet I have heard little recommendation on addressing this important factor and the risk it may pose to the workers of these shelters and motels.
Thanks for that question. It's a really challenging issue, and it's right at the intersection of the issues, the housing issue and the workplace issue are really intertwined. And if we had to do all of this over the long term, we would be trying to address a lot of the issues of social justice in housing and workplace that, right, well, what we don't like to see is a situation where the needs of people who desperately need help and the people whose job it is to serve them are at odds. And that is often the situation that's emerging with workers in the healthcare sector or in shelters. I think in some ways, hotels offer one option in terms of protection of workers, right? If there's a situation where someone, and there was, I think, some deliberation around this about whether, say, people who were considered, and this is a very difficult area to go into, right? People who were not able to care for themselves or not able to practice social distancing, right? If their ability to practice social distancing was impaired, that could potentially be a reason for them to be in hotels to protect themselves and others from COVID-19. And so that's part of the possibility. Then, of course, you have the challenge then you're adding into, right, these hotels are not designed as, right, they're not nursing homes. They don't have an incredibly advanced array of services. And there's an attempt to have different hotels for different levels of risk. But this is all, I'd say, some hotels are more like nursing homes, some are more like permanent supportive housing, and some cater to populations that may be highly functional. But this is really hard to do. And so if you add in a layer of also needing to provide mental health services on site, it can become quite difficult. And in LA, we already have this problem with our homeless shelters that we're slicing and dicing so much that we have a lot of shelters that are, say, catering to this 30 or 40 person client population, which is nice to do. On the other hand, you have 45,000 people who need shelters. And in this case, we have many thousands of people who could use protection right away. And so it's very hard to screen people into exactly the right sets of needs. I think there are many concerns about what happens to people once they go into hotels. Not just will they damage the hotel or something that say NIMBY's concerns they might have, but concerns like who's keeping an eye on them, who's making sure they're doing well. And so in New York, there was one episode where people were placed in the hotels and they died, and it wasn't detected, right? The risk wasn't detected. I'll say that one thing that we think is very important in this is the need for mobile phones as a lifeline for clients, right? That those of us who are housed, most of us on this call have mobile phones probably, and we use those mobile phones a lot. We depend on them for everything. But if we're housed, we have many things that we don't have to depend on a mobile phone for. We have other ways of communicating. We have other backups. We have other safety nets. We have our physical birth certificate stored somewhere. If you're homeless, in a way, a mobile phone is just an incredibly important lifeline to a whole array, just to be able to keep in touch, to be able to ask for help, to be able to keep track of lost records. And of course, people who are unsheltered, have typically depend on libraries and Starbucks and other public settings to gain internet access and to charge their phones. And now they don't have access to that. So one of the things we really want to work on is a much more comprehensive plan. And it's something we're hoping that a lot of students from our school will get involved with the planning of. That is a plan to roll out. There are already phones that provide access to programs for our poorest citizens, but most of them depend on having an address and on having a lot of paperwork that may be more difficult. So thinking about the operational challenges of getting everybody a phone is one thing we're also working on.
Great, thank you, Randall. So our next question is from Suzette Aguirre, who's an alum of the Department of Community Health Sciences, one of our former students. There's currently countywide testing for high-risk facilities, such as long-term care facilities. How can we push for countywide testing for prisons, jails, and detention centers? I'm not sure who might want to take this. Randall, do you want to take, or Linda?
Yeah, I can take a first stab.
Thank you.
Is the question was what can people do to make that push?
Yes.
I mean, you know, I'll say first of all, the push, you know, the need is great, right? That just to be clear on the specific issue of homeless shelters, not only have there been numerous outbreaks in homeless shelters in New York, Seattle, Boston, San Francisco. In Boston, there was a shelter with 36% COVID-19 positive. But it's also the case, as you might expect, that you can't simply that contact tracing is difficult. And even sort of the most basic forms of contact tracing defy the transmission pattern. So in the shelter in San Francisco, where there was the outbreak, where they did testing, not because there was an outbreak, they did testing because there were a few positive cases. And what they saw was that nobody around the positive cases, like in the direct proximity, had COVID-19, but a large number of people elsewhere in the shelter did, right? So the point is we need, as we know, we need testing in places with big outbreaks, we need testing in places with small outbreaks, we need testing in places with no outbreaks in order to understand what we need. How to get those, I mean, I think it's a really good sign that we now have, at least on paper, testing on demand in LA County. But certainly, I think if you work in a shelter or you work in a community where there are risks that are known, then I think raising them to the media, I would say go directly to your county supervisor, frankly.
I would just add, oh, sorry. Go ahead, Chandra.
Go ahead, Linda.
I would just add that testing is important. It is a secondary level of prevention. So to me, it's really critical that someone mentioned earlier universal precautions, that we continue to use primary types of prevention and maintain, no matter what, some of the other precautions that we know should be taken, maintaining safe distances, ability, access to hand washing and cleaning surfaces, et cetera. So I would just add that. Don't just rely on testing. Chandra?
Exactly. I would encourage a focus on primary prevention, but also thinking about what does testing offer. We typically do testing for two reasons, diagnosis or screening, and we want to actually prevent. So I think screening would be helpful here, in part as a way to compel greater attention to these places where there's congregate housing, and to compel other kinds of actions beyond merely documenting the need for attention in these communities.
Great, thank you. So there's actually a great follow-on question. This is from Denise Johnson, asking Dr. Ford if you could please speak to the intersection of race, incarceration, and COVID-19.
Thank you for the question. One way that Dr. Kamara Jones tries to operationalize health equity is by saying that we should value all lives equally. And we know from, much of the work on mass incarceration that part of what happens is not all lives are valued equally. In the context of the COVID-19 pandemic, we see this playing out in a number of ways, but health equity researchers are certain, even though we don't have all the data yet, that given the conditions of congregate housing, mass incarceration, and so forth, that we will expect to see over the long term much more, much starker disparities among highly policed neighborhoods, and especially for Black and Brown communities for whom that's true. So there is no way to think about the implications of policing, of incarceration without thinking about the ways it's racialized and the implications then for disparities among racial and ethnic minority communities. It's also important to think about the implications not just for those who are currently incarcerated, but to think about the network implications and the implications for transmission within particular populations and groups, because it really affects the way that the dynamics of the epidemic or the pandemic in that respect. So these are critical questions. I would say that health equity researchers and health equity advocates really believe that fighting for abolition, for instance, is critical and appropriate. Abolition of the carceral system in this moment, precisely because of the nature of the magnitude of the epidemic that we expect to fall out as a result of inattention to these intersections.
Thank you, Chandra. So our next question, I think, could be for any of our panelists. This is from Julie Popovic. I work as a nurse practitioner at a local ER. I find that my patients come in with suspected COVID who are safe for discharge home, usually live in small homes or apartments, housing with multiple generations. They fear infecting the elderly they live with. They have very limited resources for other temporary housing to avoid transmitting illness to their families. Many, because of low socioeconomic status, live in very close quarters, making it impossible to self-isolate at home. I called LADPH and they could not provide me with any guidance on this matter. What are your recommendations?
I mean, I'll say that the hotels really should be for everyone, which is that anyone that in any situation where people can be protected, either by being put into an isolated space to protect themselves, or being willing to move into an isolated space to protect others, that is something we could be doing. And it's why, you know, the fact that we're at 2,000 against a target of 15,000 is frustrating, because the real target should have been much higher. We have 110,000 hotel rooms in this county. The vast majority of them are empty. These could have been used not just for vulnerable homeless people, but for people being released from jails and prisons, and for people who, for a wide variety of reasons, would like to be isolated and simply can't.
I don't know if any of our other panelists want to weigh in on this one. Okay, I'll go ahead and go. We have, thankfully, we have a great audience, an engaged audience. We have lots of questions here. I'll try to get through as many of them as we can in our last few minutes. So this question is for Linda Delp. What is your recommendation for how community members can help advocate and support workers who have to be out on the front lines? The challenges seem immense, with agribusiness being so strong and the healthcare industry becoming increasingly run solely to make money for investors. Are there worker organizations or unions beyond the flight attendants that are trying to take a strong stand?
Thank you so much for that question. I would say, number one, what can you do? Vote. I think that's critical for all of us who care about public health. Number two would be certain groups have, especially in particular low wage and immigrant workers, there are worker organizations that have set up funds that community members can donate to. This in particular helps to support workers who've lost their jobs, which is many workers, and particularly immigrant workers have a more difficult time getting access, undocumented immigrant workers getting access to benefits. So I think donating to support some of those worker centers and worker organizations could be important. And then I would say, yes, there are labor unions, the LA County Association of Labor, at the national level, the service employees, unions that represent workers, the United Food and Commercial Workers, which I mentioned before, that represents grocery and meatpacking workers, et cetera, are joining forces together with a national coalition of coalitions of occupational safety and health organizations across the country. There's one here in SoCal Kosh in Southern California to really push for policy change. So I would be happy to share. I'll add some resources. I'll submit them to the School of Public Health so they can be added to the website when this is posted, so that you know how to contact them, but also contacting your own legislators. So right now, at the federal level, there is no OSHA infectious disease prevention standard. So labor unions, worker advocacy organizations are pushing for OSHA to develop a standard to protect workers across all industries. Unlike in California, where our aerosol transmissible disease standard is specifically for healthcare, nursing homes, home care, and actually homeless shelters as well, but not for general industry. So getting politically involved, I think, would be critical, and then providing support through worker advocacy organizations.
Great, thank you. So we have a final question for all of our panelists. This is from Susan Ahmed. How do you all see our social systems progressing to better address some of the health disparities that have been highlighted by the pandemic when things go back to quote unquote normal?
Let's not let them go back to quote unquote normal, I would say. Let's try to find opportunities that are peeking through some of the challenges we face in this COVID-19 public health crisis, because it's been really clear that the systems and structures that we have in place are fragmented and broken, and workers, homeless people, and the population in general who have exposure are falling through the cracks of protection. So we need to look at all levels. I would say we need to look at investing in public health. We need to look at investing in stronger worker health and safety protections for workers. We need to have a stronger social safety net so that we're better prepared, and make sure that we are looking at all workers, all people across the spectrum, and not just those who are more privileged than others.
I would just add to that, I think it's clear in a moment like this that a broad focus on equity and systems and justice is incredibly important. And yet you also see, right, that there are a lot of things we can prevent if we had a more just health system. At the same time, there are a lot of unpredictable events that come up. Like this is just an illustration of one of many events. We've just in the last few years, we've had other epidemics, we've had fires, we've had heat waves, and I think resiliency is a form of justice, and resiliency is critical to equity. And so I think thinking about systems that are more person-oriented, that I think within the homeless system, if you think about the number of people that are at risk, the number of moments of risk when someone is potentially going to go into housing and then fall out of housing, or is going to, that there are so many moments when the path to recovery can fall apart. And yet the systems that we have, like the whole person health approach, that really tries to think about the person and healing the person and following them on a path to recovery, that's a system that covers 1,000 people. And I think we need to think about ways to use technology, to use systems, to use neighbors and existing social networks to take a much broader approach to building resiliencies for people who are living on that edge of that cliff.
I would say that in addition to our public health infrastructure and the systems provided by our elected officials, that we can expect to see a stronger, more engaged citizenry, that we will see more citizen scientists and people in communities conducting community-driven research using big data and strategies along those lines. I think that this pandemic presents an opportunity for collaborations across different unexpected, communities, including diverse communities of color. And I also think that we will see changes to the carceral system, that it was already in a state that required immediate attention. And the pandemic is really underscoring the need to do something because it's not really working for our society in general, and it's contributing massively to social and health inequities.
Great. Well, I want to thank you all, Dean Brookmeyer, Linda Delp, Chandra Ford, and Randall Kuhn for being with us tonight. I also want to say thank you to our communications team behind the scenes that has made tonight possible. Thank you for providing us with a deeper understanding of how COVID-19 is differentially impacting specific subpopulations, what we need to be aware of, and what we can possibly do as a society moving forward through this pandemic and beyond. I hope all of you will join our school next week, Tuesday, May 12th, when Dr. Michael Prelip, Professor and Chair of the Community Health Sciences Department, will lead a panel discussion addressing COVID-19 wellness and healthy living. Until then, thank you so much for joining us. Please visit our website, ph.ucla.edu, where the video of tonight's presentation will be available later this week. You can also find COVID-19 information, including facts and tips in more than 6 languages and links to additional resources on the website. We wish you continued good health and safety. Thank you again, everyone. Good night.